Well, good evening, everybody. Welcome. I just want to say before I start that you have made a Jewish mother's heart feel full. I'm looking at your plates, and I am delighted. So, eat well. So, for those of you who don't know me, I'm Shelley Cohen-Conrad, and I'm here to welcome you from our Center to Advance Interprofessional Education and Practice. And I'm so excited to see you here. We fondly refer to ourselves as CAPE, just to make it a little bit easier. We are so delighted to have Christine Arenson here tonight. We've known each other for a long time, been on a long journey, and she's going to talk to you tonight about ways in which IP is growing and changing and how we can use these in advancing what we're doing here, especially around moving forward to developing clinical sites and clinical opportunities and the meshing of academic learning and clinical practice. So as I look around the room, I pretty much know almost everybody here, which is an amazing experience. There are a few of you I don't know. Holly, I know pretty well. She knows how I love having my picture taken. I know, I'm like... and so for those of you who don't know, we started our interprofessional efforts over lunch. And we began with about 6 people. And as we ate together and built relationships and shared ideas, right, Karen? We had wonderful experience of sharing food. And over time, we grew from 6 to 10 to 20. And when we hit about 60, we decided we could no longer serve lunch. So tonight, we're having dinner, lunch is dinner, to celebrate our all being together. And so please, please enjoy. So before I introduce President Herbert, I really want to thank everybody who helped to sponsor the event tonight, to support the event tonight, and especially I want to call out Chris Hall, Michelle Cody, Lee Cody, Dave Daniego, and Parkhurst. The staff at Parkhurst have been amazing. So it's my sincere pleasure now to introduce James Herbert, UNE President and amazing IP supporter.
Well, thank you.
Thanks, James.
Thank you, Shelley. So thank you very much, Shelley, and it is nice to see everyone tonight. And I'm very happy to be here for many reasons, one of which is that there are latkes over there, and I understand that Shelley is going to lead us all in her famous rendition of the dreidel song. Ready? Dreidel, dreidel. Okay, so anyway, in all seriousness, thank you, Shelley, for hosting this, for being here. Dr. Arenson, thank you so much for coming. I've enjoyed our time together and talking with you. Fun fact, we lived for many years without knowing each other about less than 2 miles from each other on the main line of Philadelphia, and we both have daughters who were in high school at the same time, and both went into engineering. And so we're pretty sure they know each other, although we're gonna find out. But it's a fun fact. So I wanted to thank Shelley for everything she does to lead the Center to Advance Interprofessional Education and Practice. This is one of the hallmark features of UNE that differentiates our healthcare training and practice from others. Our students and their future patients are really lucky to have the center and all of the people in it, all the people who participate in this enterprise, and I'm just very grateful. Thank you all. And it's wonderful to see so many of you, our professional staff, some students and faculty, of course, together tonight for this sort of celebration of our IPE efforts. Tonight, we welcome a luminary in the field of interprofessional education to share some of her wisdom with us, as I mentioned, Dr. Christine Arenson, as we celebrate UNE's deep connection with the National Center for Interprofessional Education and Practice, which she leads. Established through a unique public-private partnership, the National Center offers and supports evaluation, research, data, and evidence to galvanize the field of interprofessional practice and education, and to lead to better care, added value, and ultimately healthier communities. Our UNE Center has worked closely with the National Center since 2012, but before I got here. And it was one of the first universities in the Northeast to be named a Nexus Innovation Network partner, connecting us to a national group of collaborators who participate in testing the effectiveness of IPE and various collaborative practice models to improve healthcare practice and outcomes. And I have to say, when I was looking at UNE, one of the things that stood out to me was the deep commitment to IPE. I told a story earlier to Dr. Arenson that in my former institution, it was hard to get the dean of our medical school and the dean of our health professions college to actually be in the same room without throwing things at each other. And they just would hardly talk, much less really try to coordinate. And I was so struck at UNE by the way that our faculty, our professional staff, our administrators just worked together seamlessly, and it was sort of baked into the DNA. And that doesn't happen by accident. That requires the efforts of many people, and it requires leadership. And Shelley, you've been at the forefront of that and since long before I was here. So thank you so much. And again, through the years, our UNE faculty, professional staff, and students, they've been frequent contributors to the National Center's conference, the Nexus Summit, and Shelley and her colleagues play a part in designing the conference every year. Our guest this evening, Dr. Arenson, joined the National Center in 2020 to serve as its director. She is a board-certified family physician and geriatrician with significant education and practice leadership experience. She served previously as the founding director of the Division of Geriatric Medicine at Thomas Jefferson University Hospital in Philadelphia. And as you might imagine, her work in geriatrics, including significant focus on home and community-based care in helping older adults to remain independent in their communities. This naturally led her to working with colleagues as members of interprofessional teams. And inspired by these experiences in the field, Dr. Arenson and her nursing colleague, Molly Rose, co-founded the Jefferson Center for Interprofessional Practice and Education in 2007. Tonight, Dr. Arenson will share some of the lessons she has learned about the importance of building successful university-community partnerships to improve health professions education and, in turn, patient outcomes. And I'm also happy to say that we have some of our key university partners with us here tonight, key healthcare partners, rather, with us here tonight, and I'm very pleased to welcome you. So please give it up, a big nor'easter welcome for Dr. Christine Arenson.
Thank you so much, President Herbert and Shelley. It's really a pleasure to be here. We really do look to UNE as one of the leading lights of interprofessional education. So for me, it's just a treat to get to be here and meet you and hear some of what you're chewing on, which is what we're all chewing on, I think, in this field. So it's been a pleasure to spend the day. I get to spend another day on your campus tomorrow, on a different campus tomorrow. So thank you for all that you do. And President Herbert mentioned the Nexus Innovation Network. And, you know, what we know at the National Center is some from our personal experience. Our founding director, Barbara Brandt, led a center to teach, do the work that you're doing with students every day, as I did. But most of what we know is from our partners and from learning together with, from, and about each other in true interprofessional style. So what I'm going to do is summarize a little bit where I think we are in the field, where I would suggest we need to go. And I can say with great confidence, spoiler alert, after spending the day on your campus, you all are poised to really be leaders in this work. So hopefully I won't take too long because I'd love to have some conversation before I leave the podium. So I have no financial relationships other than being my job, director of the National Center, to disclose. And I want to start kind of giving you the preview before I give you the talk. So what I hope to do is to make the case, in case any of you are doubters, that interprofessional education really is a critical component of modern health professions education at the pre-licensure level for sure, but also at the graduate and continuing professional development level, that we really need to be thinking broadly about our learners. that foundational didactic and simulation education is really critical for our pre-licensure students to teach them the context and the science of interprofessional team-based care and to provide opportunities for them to practice in safe places. It's necessary but not sufficient. And so what we really need to do, I believe, is to take advantage of the healthcare and education systems crises that we are facing as a nation right now as an opportunity to really reassess how we provide care, the outcomes that we achieve for the individuals, families, and communities that we all serve, and where, as interprofessional educators, our particular expertise offers one tool in the toolbox to help to fix that situation and how we can really make a difference in health, for the health and social care workforce, but also for the health outcomes that we all care about. So I've been using this quote. We've been doing a lot of work on the history of IPE at the National Center, which we date back at least to the early 1900s, and actually that was a physician social work dyad at Harvard that had amazing, well-documented outcomes and got disbanded when other physicians found out that a woman social worker could help outcomes. So again, thank you to Shelley leading the charge. But this was from 1974, at which time there was actually a big push for interdisciplinary education. Ed Pellegrino, who was very famous in medical education circles, actually led an IOM report at that time. And there were a lot of conferences around the country talking about interdisciplinary education, what was happening as technology suddenly caught up and then allowed us to do things like ventilate people, but we didn't know how to stop ventilating in the 70s. Whether we had new professions coming online, maybe old professions were going to disappear, and people didn't know what it was. And I think often we still don't all agree on what it is. So with that, I'm going to just frame my remarks with our definitions at the National Center. So when I use phrases and words, you'll know what I mean by them, and feel free to argue with me about it afterwards. So when we talk about IPE, we very intentionally, since the very foundation of the National Center in 2012, have used the expression interprofessional practice and education. And when we first started, we called that the new IPE. Many centers are using that language now. But it gets back to our understanding that we can't do this just in education. It has to be practice and education together, and that really practice comes first and education follows in many ways. We have adopted, but with a slight adaptation, the World Health Organization 2010 definition of interprofessional education, which is when students from two or more professions learn about, from, and with each other to enable collaboration to improve health outcomes. And that, to us, that the reason to improve health outcomes is really critical. We drop the word student because we really feel very strongly that we cannot change healthcare if we don't work with the existing workforce as well as with our students coming on. And what we call the flip of IPE is to really think about different models of academic community and academic health system or practice partnerships that can really work across this whole spectrum at the same time. And when I say health, I mean health, not healthcare. We use the World Health Organization definition of health as not simply being the absence of disease. And when I talk about the nexus, this is really a core principle of ours. Again, we've used this since our founding. We talk about the nexus as being the place where we can bring practice and education together to simultaneously transform both with the goal of achieving improved health outcomes and learning outcomes at the same time. And I'll talk a little bit more about what I mean by that. But when I say nexus, this is specifically what I mean. So laying a solid foundation. We know a lot about this. IPE has really been on the uptick. We call it the IPE Renaissance when we talk about the history of IPE since the To Err is Human report came out in 2000. and the quick follow-on a couple years later, Health Professions Education, A Bridge to Quality. There have been enormous resources put into interprofessional education. The center that I helped develop at Jefferson was founded because of that. I'm sure your center initially started working because of that, as many others did around the country. And as a result of that, and as a result of a lot of our accrediting organizations coming together to think about this, we have some really core key tools. So we have the IPEC core competencies for interprofessional care, which, if you're familiar with this but not deeply familiar, their brand new 2023 update was just released about 2 or 3 weeks ago. So this is the first time I've had the 2023 slide, which really help us to define what the content of interprofessional education should be. I think people sometimes forget or don't realize these are core competencies for interprofessional collaborative practice. They are not core competencies for pre-licensure students. And that's a subtle but important distinction I would call out to you. The domains have been stable since the first competencies came out in 2011 and are very consistent with our colleagues in Canada and with the World Health Organization. So those 4 domains of values and ethics, roles and responsibilities, communication, teams, and teamwork continue through in the new version. The subtle details have changed. There's more emphasis on DEI issues now, which were largely absent from prior versions, an attempt to sort of streamline the number of competencies, but the domains stay the same. In 2019, after about a 2-year effort, the Health Professions Accreditors Collaborative, which represented almost 30 health professions accrediting bodies, released this guidance for developing quality interprofessional education for health professions, which does not create lockstep. Our accreditation standards exist for interprofessional in most of our professions now, but they are not the same. They're not necessarily reviewed the same at site visits by different site visitors, but the core intention was really defined in this document to help people understand at a programmatic level across the university what the accreditors are looking for in broad brush strokes, obviously to be adapted and applied locally. This is one particular list that was developed by one of the early luminaries of IPE, Bud Baldwin, who was a mentor of mine and Barbara's. From, I think, 2007 is when this list was published about the barriers to IPE. And all of these will ring true to everybody in this room. It's really hard to find time. It's hard to find role models in practice. There's this really linear lockstep model of professional education, maybe especially in medicine, but in all of our professions. We all have certification and accreditation requirements that have to be our first priority. Our students have to pass their boards. Nothing else matters if they can't pass their boards. I put this up here not to say these are real, they are real barriers, and I lived them, as you all do now, while I was doing this work on the ground at Jefferson. But you all have figured these out. You have some amazing programs that you're doing, and I really want to sort of give you a minute to celebrate that amongst yourselves. You know, you have these, the team immersion program, probably the star of your programs, but simulations that you're developing, mini grants, and I put in caps at the bottom. This university, I would say, is the national leader in how we engage patients and community members in educating our students and helping them to really practice patient-centered care instead of speaking the talk, talking the talk but not walking the walk. So again, kudos. Pat yourselves on the back. Give yourselves a round of applause. So celebrate that. It's really good, important work, but you're not done. And this is just some headlines that Barbara and I have been collecting over the last, well, some of them are older, that really document why it's really critical in our interprofessional education literature, why we need to move into practice, why that foundational curriculum is necessary but not sufficient to really prepare our students, and why working just with pre-licensure students is not sufficient to change the way we deliver care in this country. So we have a lot of work that tells us this. I put up here, this is the shameless self-promotion slide. We just published a special issue of the Journal of Interprofessional Care in September in recognition of our 10th anniversary at the National Center, and this synthesizes our sort of sense of the environment and our recommendations for the field moving forward, but does it in the context of 12 or 14 papers from partners and colleagues of ours from around the country, and kind of what has been learned locally that's helped us to kind of put together this bigger picture. So I'd encourage you to take a look at that. The bottom line is, I think this is a moment in time that calls for us to really be reflective about how we're educating both future and current practitioners, and to do some myth busting. If you haven't seen, this is a phenomenal edition of medical education. The entire edition is around myths in medical education. It's more focused on physician education, but much of it is pertinent across health professions. And this particular paper that we call out was written by co-author is Barrett Michaluk, who's the director of IPE at Arizona State University and is a medical sociologist. So they talk in this particular paper about what they call the unbearable necessity of mythology in medical education, and why we do certain things the way we do, and why we need, and that's maybe okay, sometimes it is okay, but sometimes it's leftover stuff that's no longer pertinent, and we need to give it up. We need to move on. So I'd encourage all of you, I'll come back to the concept of myth busting today. So I would like you all to I'm gonna literally give you about 30 seconds to stop and think. You can talk to your neighbor if you want, or you can do this yourself. What is happening on the ground today here at the University of New England and at your clinical partners that's impacting health professions, education, and practice? What are the characteristics of interprofessional education today? What are the characteristics of team-based care today? What is going well? And what goals do you aspire to that you have not yet achieved? Okay, keep those aspirations in mind. I'm going to tell you a story about myself. Some of you have heard parts of this story earlier today, and I'm going to give the abbreviated version. So I spent 10 years as the founding co-director of our Center for Interprofessional Practice and Education at Jefferson. I helped establish a division of geriatric medicine, built up academic programs, sat on curriculum committees, got lots of strokes for that work. It was fun. I had wonderful colleagues. And then my chair left, and I was asked to step in first as interim chair and eventually as chair of the Department of Family and Community Medicine, and I did that somewhat hesitantly. But I was very excited about one thing, which was I was so frustrated with how slow the pace of transforming our primary care model to team-based care was. And my former chair had been my residency director. He was my friend. I was on his leadership team. I had nothing to do with running the practice. I didn't want to have anything to do with running the practice. But darn it, I knew that my good interprofessional skills could fix that in a few months, what he hadn't been able to do in the last 10 years. So that didn't work out so well. But it did lead to me understanding the whole scope of how practice actually happens. Scopes of practice from a legal perspective, what gets paid for, what doesn't get paid for, what's driving the hospital administrators that I just thought didn't want to give me money because I knew they had them. I didn't have a money tree, but they had a money tree. They only would give it to me instead of the neurosurgeons. So it was like being an intern again. The fire hose that I was drinking out of what I didn't know until I was suddenly responsible for practice administration, not only locally, but as part of a team looking at a whole service line across very disparate types of practices. So it really made me stop and realize that all the interprofessional expertise in the world will not get us there if we don't understand the context of where we're practicing, why things are the way they are. And then you can have conversations with people from different parts of the system where they are and figure out how to solve their problems. And then you can start to change. So that was my personal wake-up call, frankly. I think that experience is part of why I was recruited to the National Center, because they were really looking for somebody with some practice experience, because we knew we needed to get there. And then, so I was scheduled to leave Jefferson and move to the University of Minnesota on July 14th, 2020. And I had a grand plan for how to spend the last 6 months of my career, of my 30-year career at Jefferson, saying goodbye to people, handing off to the interim chair. And then the world shut down in the middle of March. And I spent the last 3 months I was at Jefferson in scrubs with a N95 mask on my face, trying to figure out how to convert all of our primary care practices to still take care of our patients in spite of COVID. And we did things in 5 minutes that we couldn't do in 5 years before, right? Because we just had to. We all had to do different things, and nobody questioned it. Because especially for those 4 months, we didn't think it was a 3-year slog. We thought we were going to, 6 months and then we'd be good, right? So people were happy to do whatever we needed, and we could experiment and we could change everybody's job descriptions literally every 2 or 3 days. We were very fortunate at Jefferson. We had a huge supply of PPE. So we were one of the first hospitals in the country that everybody was masked, including the medical records staff who were dying in New York City at the time because they didn't need masks. So we had this tremendous opportunity as I was leaving the door to see what, not let a crisis go to waste. Now, unfortunately, like everywhere else, COVID didn't end in 6 months, and the world hasn't gone back to normal. And instead, we're living in this incredible crisis, ongoing, slow-burning crisis that the health system is living in. But it's still an opportunity for us. So our call at the National Center, and this is from the editorial at the beginning of that special issue, which Barbara wrote, is we have to work on changing our underlying ideology and culture, that both within and across our professions, and within and across institutions and traditional boundaries. We need new mental model about what it means to be a professional, and what the professions are, because we have evolved dramatically over the last 30, 40 years, certainly over the last 100 years. Physicians started as a guild in the 16th century in Scotland. I don't think we want to be a guild anymore, not if we want to really make a difference in health. And people who want to make change have to understand how all the parts of the system work together. Because as we know, every system is perfectly designed to get exactly the results it gets. We're not getting the greatest results for the people we serve in the United States, but we can't fix it by twiddling on something over here and not understanding how that's going to impact something over there. So we call this knowledge-based interprofessional practice and education leadership. And that's, those of you who follow us at the National Center, you're going to hear us talking about this a lot in the short term. And we use, amongst other tools, a developmental evaluation strategy that's called What, So What, Now What. So I'm going to spend a few minutes walking you through a quick what, so what, now what exercise to get you thinking about what your opportunities are here locally. So when we talk about knowledge-based leadership for interprofessional practice and education, we talk about making sense of our past to understand how we got where we are, and then look forward from the industrial era that our current system is largely codified in to the knowledge-based economy that we actually live in now, and how do we need to adjust to that, particularly in light of ChatGPT in last year. By being aware of the everyday wake-up calls that come to us and paying attention to them and understanding that we can't work harder. Nobody can work harder right now in healthcare. We have to work differently so that we can get past these challenges. We have to work with colleagues with different lenses and different points of view, the people we work with every day and people we don't work with, to make sense of those wake-up calls. And then we need to be really conscious of the impact that industrial-era standardization has had on our work and how we need to move past that if we're really going to take advantage of the knowledge economy. So what? What do I mean by what? So most of these headlines have been called in the last week. The exception would be the one about the University of West Virginia. I think we're going to keep that on there for a while. The whole department's being closed down. But I call your attention particularly to the quote right in the middle of this, which is a headline out of, I forget which business journal. Is college still worth it? In 2023, we are having a debate in this country about whether our children should go to college. Think about that. And the Time magazine, this literally is from last week, the coming collapse of the US healthcare system. Cyber attacks, burnout, who's going to care for older adults? We don't have a workforce for anybody right now. How are we going to fix it? It's not pretty out there in either healthcare or education, higher ed right now. We have spent over 20 years laser focused on safety in this country. And in 2019, a very credible book titled Still Not Safe was published. And in 2023, the follow-up, co-authored by Peter Provenost, who is probably the biggest champion of our current strategy for safety, we've spent $47 billion to fix a problem that was thought to be a $17 billion problem in 1999. And we've reduced maybe 6% of medical errors in our hospitals. We're still not measuring them really anywhere else. This is not good. What we're doing is not working. And it's not because people aren't working really hard at it. And we're not investing resources. We've invested enormous resources, frankly, at the expense of other things we could have been doing, with one strategy, which has largely been an industrial age standardization strategy. Except that the people that we take care of are not airplanes. They're human beings that have a social situation and family and beliefs, and don't just get fixed because we send a mechanic out to fix them. What are we hearing at the National Center right now from health systems leaders? We have an extraordinary number of health systems leaders reaching out to us almost every week now. And these are quotes that these are not one-offs. They're on this slide because we've heard the same thing from multiple people in multiple parts of the country in different types of health systems. We've lost 5 to 10 years of work on teams in our institution. My clinical teams don't know how to communicate with each other the way they did 5 years ago. We've had to retrain basic customer service skills. Not for the people who answer the phone, for the nurses and the doctors. Do physicians need to lead every team? The AMA would say yes. How do we standardize team members? What's the recipe? How many nurses do I need? How many physicians do I need? How many physical therapists do I need? Just tell me the recipe. I don't know how I'll hire them or keep them, but tell me the recipe. We have burnout that's, 65-70% of the workforce now, turnover at all-time highs. Even if people have money, they can't fill their vacant positions. This is not, my friends, about individual resilience. This is about a system problem. We have seasoned practitioners who would have thought they were going to work for 10 more years who've left the field. New graduates who lacked the opportunity, I think this is changing, but in the first 2 years of COVID, did not get the same clinical experience before they entered practice as we were able to give them historically. And all this in the context of hospitals having to hang signs saying it's not okay to be violent to your healthcare team. shootings in hospitals, sometimes by coworkers, not even just patients and family members. And the incredible sense that the public, who used to trust physicians and nurses to have their best interest, not trusting us or the science that we're recommending to them. Whoops. So I'm going to have you stop and think again. What are the wake-up calls that you're seeing every day, right here in your daily, wherever you are, if that's in education, if it's in practice, if it's in both? What are some wake-up calls that you're seeing every day that we need to do something different? Okay, so once you think about the what's not going well, then we have to make sense of it. That's the so what. So here's the world we're living in higher ed, health professions education right now. We are very steeped in competency-based education and competencies. We are striving to achieve curriculum, which is often described as for collaboration-ready students. I'm not exactly sure what we mean by that, but we say it all the time. We try to be evidence-based in our pedagogy. But we're very stuck in this one right way standardization model as a country in lots of domains, but it's impacting our delivery of care and our education. It's the Ford production plant model translated to higher ed and healthcare. But we're not building Model Ts, folks. And we've had this incredible focus on standardization, practice guidelines, quality control. The EMRs were going to fix this because the practice guidelines would be there at your fingertips. Hasn't happened. So how do we listen to those wake-up calls, the ones I shared, the ones you're thinking about, and think about this world for a minute? And I'm going to point out to the president that I'm saying this. No new programs, no new curriculum, no new resources. Because just like the third arm of the triple aim, now the quadruple aim or the quintuple aim is value, we have to be thinking about value in education too. So what can we do differently with our current resources in our current setting to change things? What are we seeing? What are we hearing? Who are we going to talk to from a different lens than us to start to have these conversations and get a different point of view? And are we ready to question our most deeply held beliefs about what's right for our profession, what's right for our students, how we educate, so that we're open to thinking about new and different ways of doing things? And everything won't work, because we've got to study it too. I mentioned our commitment to competency-based education. We do not believe that competencies are bad at the National Center. We are huge supporters of the IPEC competencies. We think they are very helpful. In the last 6 months, I've been asked to sit on panels of 3 different sets of competencies because all 3 people felt there was an interprofessional piece, so they reached out to us on medical errors, on, the list goes on. And these are all, they're important things. And we all have, these are just interprofessional competencies. We all have lists, as long as our arm of competencies that we're supposed to cover for our uniprofessional curricula. We can't do this one competency at a time. We have to make everything we do and figure out how to put this knowledge in contextualized practice settings that are meaningful to our learners, where they see themselves being in the future, and then they'll get the competencies. If we just try to force feed them competency after competency and one more simulation, there's not enough hours in the day, even if that might work. So I want to give you very quickly some examples of what we mean by the kind of what, so what, now what process. And these are just a list of things. And the last one is you. So the case of the vanishing ideas. This gets back to our focus on competency-based education today. There is actually a very rich literature on workplace learning generally and workplace learning in the health professions from back in the 60s, 70s, and 80s. It essentially ceased to exist as an ongoing discipline sometime in the last 10 years or so and had petered out before that. We've gotten very focused on competency-based education at the expense of many other adult pedagogies. So why did we do that? Well, competencies are important. We need to define what people need to know. But that doesn't mean that's the only way to teach what they need to know. So I would encourage you to really think about different kinds of pedagogy, and particularly workplace learning, which if you go back to this literature, there's a very rich, evidence-based, it's very convincing that that's where people really cement how they practice. Whether they practice at the top of the license we're training them for or it's something else, they cement it in their practice experience, not in our classrooms. Example 2, what we call authentic practice, or translating interprofessional practice and education scholarship for knowledge-based leadership. So we have often, and I certainly did this at Jefferson, worked very, very hard to get all of our students in the same room together, and that was when it was interprofessional. And we would do gymnastics to create case scenarios that we thought, I had MRI and ultrasound technician students at Jefferson. It's very challenging to create a case scenario that is equally relevant to an ultrasound tech, future ultrasound tech, and a physical therapist. And so we create these things that are artificial and that you kind of you can see the logic, but the students know it's not real. And anyway, we didn't have social work students. Every single interprofessional simulation we had, the best response we could ever get from our students was, this was so helpful, it was really interesting, but I needed a social worker at the table. Well, I didn't have social work students, so there wasn't a social work student, there wasn't a social worker at the table. There were also 100 other people who weren't at the table, who they will work with, some of whom have professional licenses and many of whom do not, but are critically important in how we take care of people, whether we're in schools or in primary care practices or intensive care units. So we have to really think beyond the narrowest definition of teamwork, of a team that's literally working together every day, taking care of the same group of patients together every day. I mean, that's a wonderful experience. I've had the opportunity to work in those teams, and it's amazing. But it's a fraction of what happens in delivering health, because people aren't under the same roof, services aren't delivered by the same organization that people need, and not every patient needs the same things. In geriatrics, we spent 20 years trying to prove that every older adult needed comprehensive, interdisciplinary, we called it in those days, team-based assessment and ongoing management, because it made us feel good. And it turned out there's a very small slice of people for whom it actually makes a difference. And they're not the sickest people because it doesn't help them. And they're not people with cancer because they have a really good team at a cancer center if they're at a decent cancer center. It's the people who are on the margins of frailty, who want to stay at home. For them, that intensive work actually makes a difference. For people who are really healthy, just have a bunch of chronic conditions that might someday make them frail, they like it, they get a lot of attention, yay, makes absolutely no difference for their outcomes. So we have to be critical about when do we need that intensive teamwork and use our resources wisely when we do need it, but understand that most of what we do is collaboration. So as a family doc, I had lots of patients that needed cardiologists. I wasn't in a team with the cardiologist, but I knew if, I had a young woman who had an arrhythmia, this was the cardiologist that was likely to resonate best with her. An older person with, heart failure and coronary artery disease, this was the cardiologist. We collaborated. We adjusted meds together. We talked to each other, but we weren't a team. Very often, we're just coordinating care. I'm not a social worker. I don't have social workers where I work, but I know where there's a senior center, where there's a social worker who can help you understand what your benefits options are. And I can coordinate a referral. Or just networking. I know that if you call the Alzheimer's Association, they have support groups you, family and caregiver, can join. All those are valuable and important, and we should acknowledge that. It's not all that core, highest level of team working that our patients need or that we're going to be delivering in practice. And we have to provide those opportunities for students to see those different levels and value them equally as appropriate. Do we have a coalition of the willing? And this is what we're hearing from schools that have been doing IPE for the last 10 to 15 years with volunteers who have been working really hard. But some of that first core group of committed volunteers have moved on to other jobs within or outside of the institution, and others haven't really backfilled, and they're tired. And not everybody shows up at the table or seems to value IPE, sometimes even when they're reporting to the same person. So why is that? Why is it not resonating with the faculty? Why is it not resonating with the students? What do we have to do differently so that we're not exhausting the good-willed people who are doing good work, but we're really getting to the outcomes that we want? I'm going to skip this because I kind of talked about this already. This is Maine from last week. Medicaid expansion was going to solve access to care, right? Turns out you actually have to have caregivers to solve access to care problems, and especially in rural areas. So this, I think, Shelley, you shared this with me, but just astonishing statistics about how long it takes for an insured person to get a primary care provider because wait lists are closed, for an insured person to get her child with an acute dental problem, not even into routine dental care, just to get an acute problem taken care of. And it's not an insurance issue, it's a provider access issue. And it's not just Maine, although it sounds like you're really dealing with this in Maine. Why is that? And how can interprofessional collaborative practice make a dent in that? So that's all the so what. It's a lot, but it's a lot of opportunities. So I'm going to spend the last couple of minutes talking to you about what we recommend as some of the now what. So what are we going to do about these challenges? This is a model which I'm not going to try to describe to you today, but this is what we are now calling our Nexus IPE learning model. And it's in the special issue that I shared with you about that really starts with the North Star of patients and people served at the top, talks about how do we bring partnerships together in the nexus of practice and education, what we need to do to develop those partnerships. These things do not happen overnight, and taking time to develop the partnership is really important. I've heard snippets of conversation about work that's happening here in that space. It's very exciting. Then we have to look at the what, so what, now what. Can't boil the ocean, but where can we start to make a difference? And then this is based on our work with over 100 projects and many people. We've developed some process things that we know make a difference. Critical success factors, which are alluded to on this graphic, and then some strategies for documenting outcomes. And again, we use a developmental approach because this is not a randomized controlled trial where you're going to hold everything constant for 3 years and then break the code, right? This is rapid cycle process improvement. We do something, we look at the data that's good enough, never perfect, whether that's learning outcomes data or clinical outcomes data, and say, did it get where we wanted to go? Did it at least get us directionally there, or was it actually it broke something that we didn't know was working and we need to backtrack? Our model is very much grounded in the model that was published by the Institute of Medicine in 2015 that is really a model to look at how do we document the impact of interprofessional education on outcomes that matter, both learning and health outcomes. And as you can see, this model envisions working across the continuum of education. We know most formal interprofessional education that's happening today is happening overwhelmingly it's in pre-licensure education, and overwhelmingly that's in preclinical pre-licensure education. We need to move into advanced degrees, and we really need to work with our colleagues in practice to help people understand stuff they were never taught. How can you collaborate effectively with someone who you don't even know what their scope of practice and their training is? So you have ideas born out of misinformation that you were taught about what someone can and cannot do. You can't collaborate effectively in that setting. It's why roles and responsibilities are a key domain in the competencies. We've modified this a little bit, and mostly the reason I'm showing this slide is our work overwhelmingly shows us that we need to start with the outcomes that matter for the population served, and the learning outcomes will follow. When we start with learning outcomes, that's what we do, right? I have to write a document for my accreditors that they know that I'm doing this. But when we start there, in isolation of what's happening in practice or what people that our learners will be involved with in their practical rotations are doing, we'll get only so far. When we start with the needs of the population and think about how to design the care to meet that and then bring learners along, they're going to get their competencies. They're going to get their interprofessional competencies and their uniprofessional competencies in those settings. It is unquestionably true, I would say unquestionably true, the literature has, I don't think this is controversial, interprofessional teamwork may be it may even be our strongest lever to address the workforce crisis. It's the one thing that consistently falls out as predictive to protect against burnout and changing jobs. It is not another yoga class that does that. There's a whole bucket of systems issues related to how we pay for healthcare and so forth. Those of us in this room are not going to fix those issues. We can advocate for them, we should. This we can help with. We have expertise here that we can bring forward into practice. And this is where I'm going to come back for just a minute to workplace learning, because we are not going to affect practice for our currently practicing professionals by having clever, witty, one-hour segments of CEs. We're going to do it by helping them look at what's happening in their practice, look at quality improvement, look at outcomes that they're not happy with, they're not achieving their goals, we're hearing from patients, this is not working for me, and working as a team in their practice to address those problems. Now, it's not so different than what we've tried to do with quality improvement and safety for the last 20 years, but it's a little bit of a different focus. Again, it's not, we can have zero harm. It's, why are we having bed sores still on this unit? What are families and patients telling us about this? And how can we together as a team, not nurses are doing this and the physicians are blaming the nurses and doing that, and social workers are trying to get the patients out of the hospital faster so the bed sores don't get noticed until they're in the nursing home. It doesn't work. So, quick one-pager on what we mean when we talk about sort of traditional interprofessional education versus what we mean when we're talking about workplace learning. So traditional, we'd say creating these formal training activities to teach specific skills, both interprofessional, separate usually from uniprofessional skills, outside of practice, very structured, very standardized, designed by experts, which can lead to a hidden curriculum of, why did I have to do that? That was such a waste of my time. It's not on my boards. And those interprofessional competencies may often be seen as irrelevant or marginal to future practice. Workplace learning is happening in authentic practice settings with real-world teams where both uniprofessional and interprofessional skills are being taught simultaneously. We have done this forever in health professions. We have always sent our students out, whether we call them practicums, field placements, clinical placements. All of our students go out, and we trust, and we verify, but we trust that they're going to get their uniprofessional competence. We have not trusted that with a little bit of guidance and mentorship, they can also get their interprofessional competence. We have said interprofessional practice doesn't happen the way we want it to, except in some select cases. But there are bright spots all over the place. And there are certain specialties and disciplines where payment models demand interprofessional practice. Again, it may be better or less good in different settings. Our students are smart. they can figure that out, and they can figure out when they're seeing good and when they're seeing bad and how it's different, both for the team and for the people served. All we have to do is give them a little bit of guidance around the margins. Facilitated learning and practice, which is, again, that's giving people scaffolding to know what they're looking for, helping them to debrief. Ideally, in a perfect world, it would be working with our preceptors. We know they don't have time, but there's some things we can do. And really guiding the learner to reflect on what they're seeing in practice. We have lost or perceived that we have lost the time for reflective practice. And it's a great loss to us as professionals and certainly to the people that we're serving if we don't build in reflection to what we're doing. Because how can we do it better if we don't think about what we did? And then learners will see, when the teams actually communicate with each other, that's actually better and easier than when they don't. So always, 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 we have some version of this slide in everything we do at the National Center. We have to be here to improve health. Yes, we're here to expand the workforce, to give excellent experiences to our students so that they can be great practitioners and have wonderful careers. But ultimately, we're here as part of the health system. So I've covered a lot of ground. Quick summary of what we mean by the what, so what, now what of knowledge-based IPE leadership. So last, stop and think. What is one challenge you're struggling with right now, and how can you envision that this framework might help you reimagine? Oh, that's a Jefferson phrase, an old guard Jefferson phrase. Rethink about what you're doing and how you can get to your goals more effectively without working harder, without new resources, without new curriculum, within contexts that you can impact to start to make a difference. Thank you so much for inviting me. And I'm not sure how much time we have, but I'm happy to stay up here as long as we have.
Thank you so much. I really enjoyed your talk. And I was making a few notes because one of the things that struck me, beginning with the competencies and ending in the end with the workplace and the integration of practice, is it seems as though a competency for IPE is this persistent curiosity and being open to constantly learning new strategies, new things. The idea of innovation and how does innovation intersect with this? Because certainly as we think about the industrial age, where everything was very prescriptive, we do much of what we do in healthcare because somebody told us to do it that way, and so we do. So to me, this notion of innovation, curiosity, receptivity to change, a little adventuresomeness, because every change we make may not be positive, and of course in this industry, that can be dangerous with patient outcomes. So I just wondered about your reaction to that, because when I think about the competencies, this persistence of curiosity, and
I think that is a great description of why we use developmental evaluation as our framework rather than other research methodologies, because the what is being curious about your environment. The so what is, so what does it mean? And the now what is, how do I innovate and do something different and test it? And, look back and, if I do this, will my patients have a better hemoglobin A1C? So by the way, the health system may make some more money and my patients may be healthier. What are the learning parameters, again, that are good enough so that we don't let trying to achieve the perfect stop us from doing anything. And it's not the case, I do not want surgeons and nurses in ORs to stop doing timeouts. I mean, that's a checklist that has made a difference. So it's not that those standardization tools don't have a place. The problem is they've become almost all of what we're doing. So we have to, not throw the baby out with the bathwater, but also look beyond, because we haven't fixed the problem.
Thank you for your talk. Since you've spanned the nexus. I'm interested to know, particularly in the context of, we talked about you don't need an academic medical center to make an impact. But how do you find, and what are your experiences in finding shared goals between an institute that is focused on students who would then have a focus on passing boards versus an institution that is focused on the patient? And technically, they are two different focuses. Though we hope they exist in a continuum, you do have two separate entities. And I think that challenge in the nexus is finding the common ground. So I'm interested to hear your thoughts on where that exists.
It's a great question, and I think there's as many answers as there are situations. So I spent most of my career at an institution that owned its own health system, and yet I'm not sure it was really easier. They were still managed very separately. The health system largely saw themselves as financing the academic mission because of funds flow. So, there are challenges. It's part of it. I mean, what my personal learning moving into health system administration was understand where I had some expertise to solve a problem. So one example that I think has been a lot of programs that we've worked with have done is, health systems are now under a mandate to screen for social determinants of health issues that they then have some responsibility to assess. They don't have time to do it. Providers aren't necessarily comfortable doing it. If there's students rotating in a site for whom that's a logical practice experience for them, and you can put some curriculum around it so they understand, you may not be the one doing the screening, but knowing what patients that you might take care of in the future are facing in terms of food insecurity or how, name your social determinant, then now that's a win-win. Because now the students are providing something that's perceived as service by the practice setting and not just, my providers get really grumpy because they have to stay longer to finish their charting if they have students with them. So that's one opportunity. Another opportunity that we're hearing around the country is where people from the IPE team are using their interprofessional education expertise as coaches in practice teams where there are challenges. So again, where the academic team is bringing value into the health system. But you can't know where that is unless you start to have conversations with people at the in the right places in the health system. And then sometimes it's just somebody recognizes an issue that's within their scope that is not going to solve all the world's problems, but is going to be a step. An example from actually early in my work in IPE is the surgeon who ran the surgical clerkship for the medical students had trained in a place where he rounded together with nurses on every patient in the hospital when he was a fellow. And that didn't happen in our hospital anymore for, all kinds of reasons. And he saw the difference that it made to the patients, the difference in ability to communicate. Nurses didn't understand what he was thinking. He didn't know about everything that the nurses knew about. So he said, why can't we bring the nursing students and the medical students who are rotating on that floor together already, together with a nurse and the surgeon, and just do bedside rounds together for 20 minutes every day? Well, he could make that happen because he was a clerkship director, and it was on the unit where he admitted his surgical patients. And it was huge. I mean, within the first 2 months, they had 4 or 5 near misses that they caught because the surgeon and the nurse actually had a set time to communicate with each other. And often it was the students who knew the information, and they were really good at empowering the students to share what they knew too, that maybe the licensed people didn't know yet. So, it can be small things that start, and then hopefully you can build on that.
Thank you, wonderful talk. Thinking about what's framed as nurse-sensitive indicators, which I think should be named everyone's sensitive indicators, because we all play a part in that in the health system. Are we hearing about any innovative models of addressing these interprofessionally? I ask because I've been having recent conversations with a local tertiary care center about ventilator pneumonia, and how can we help the nurses find ways to get that oral care done when there are so many hours in the day and so forth. And we are collaborating to bring our dental hygiene students to the hospital to help train, help provide some of that care and hopefully make a difference. That's only one indicator, but I think it's one way we can sort of tackle some of these things.
I think that's a great example. Actually, the dental hygiene program at the University of Minnesota does that in at least one hospital, and it's been very successful. I don't think they're doing any critical care units, but they're doing oral care for patients in the hospital. I think there's, as I said, I think there are many bright spots out there that none of us know about because they're being done in practice by people who are practicing full-time. They have neither a mandate, time, and interest or the skill set to be publishing or presenting about what they're doing. So it's a bright spot that stays local. You know, maybe it disseminates to a whole hospital if you're lucky, but maybe it doesn't even leave one unit. So I think, again, we can find the bright spots if we can start to build relationships. And, you know, some of them do get published, you know, some of them are out there, but I think there's an enormous amount of good work happening in health systems that we don't know about.
Hi again. I'm going to follow with a question I asked you this morning, and we didn't have enough time to follow up on. So you made some remarks about the university's history and where you see us on the IPE and PP trajectory. And your comment was we're poised to kind of do this next thing. In your review of what we've all been about, how long you've known Shelley, talking to people today, and I know you have meetings tomorrow, what do you see as strengths that we really have to move us to this next level? And is there anything missing that you haven't heard that you say, I would really advise focusing on this? And again, we have this unprecedented opportunity when the medical school moves here.
Yeah.
We'll have this amazing array of health professions programs in a very small footprint, but it's not about that, right? It's not necessarily about having us all in the same place.
Yeah.
So how do we leverage that opportunity to get to that next step?
So it's a great question. So I would say I have heard probably all the pieces that I wanted to hear today, including really interesting tidbits that I'm not privy to and shouldn't be privy to about, different kinds of conversations with some of your clinical partners. I have seen people at the table who are really ready to think about doing things a different way and are open to new ideas, which, I think is critical. And you have a track record of collecting outcomes data and publishing it here. So I don't think there's anything missing. I think it's turning people loose. And I mentioned we have identified, we had 5 critical success factors. And I want to call out Sue Gold in the back room, who's one of your community teachers, who is also our patient advisor for the National Center. And thanks to her encouragement, very gentle, because Sue's gentle nudging, we added a 6th critical success factor this year, which is keeping our patient North Star, but also putting our patients in the middle of our critical success factors. So working with patients to design. We know that a critical success factor is interprofessional leadership on the ground, doing the work. Gosh, you've got that here. Amazing. And we know that a critical success factor is support from senior leadership. And boy, I'm hearing that here. But it means creating a safe space for faculty to sometimes fail because everything won't work or students won't love everything. We're very responsive to student feedback today, which, in many ways we should be, but we also have to kind of give them some context because they don't have the same context we do. So I think that's really critical. I mean, I'm hearing that, but I would encourage you to continue that. Appropriate resourcing and celebrating successes. And that doesn't always mean writing a check, but making it a priority. Is interprofessional work valued in promotion and tenure decisions here? I don't know the answer to that, but I would look at that in terms of a resourcing issue. Are people given time to do this work? So I think those are critical things. The other thing that falls out for us, and this seems simple, but it's hard, is having a clear, compelling vision that everybody can agree on, that both, kinds of stokes the flame, but also says we can't do everything, and this is what we're not going to do right now. We're going to focus over here. We're not going to focus over here, right? Maybe in a year, maybe in 2 years, but not right now. And I think that's, you have a newly named center with a new strategic vision, and I think that's, there, so.
As we move forward with the strategies that we're implementing and the processes we're trying to bring to the students, I'm wondering about how we measure and think about our successes. So I'm wondering, what does a student who has been like successfully brought into this interprofessional world look like, and what behaviors do they exhibit?
Yeah, so that's where competencies come in, because they are behaviors, right? And we have pretty well validated, easy to administer tools to assess it. Again, not perfect. Perfect would be observing them in simulation or doing practice observations. That's not been practical anywhere I've ever worked. You can do some spot checking. But there's tools that are well validated. So we have, I didn't talk about it today, but I'd be happy to. We have a core data set that's very carefully curated to get at some key outcomes, knowing perfectly well they're not perfect, but they're good enough and they're practical to administer. So there are a couple of different tools that look at competency attainment. The one that we use in our core data set is the ICAS, which is very widely published on. It was actually validated as a one-time administration pre-post test, and it takes a couple minutes for a student to complete. So you can actually do that consistently. We have some other tools that measure the teamness of a practice setting. Again, not the best tool, but a well-validated, good enough, practical to administer in a busy practice setting tool. And then I think, you can always look at, are there custom outcomes that are really important to you? When we talk about practice or health outcomes, they have to be customized to the situation. A health outcome for an intervention in ICU is going to be very different than a health outcome that you could possibly hope to achieve in, a school-based clinic. You name your setting. So those have to be customized, but again, we really help people to think about the data they're already getting, and it may not be perfect. I can tell you, I spend an awful lot of time as a chair of family medicine explaining to my seniors, leaders, why my practice that had 30% medical assistance patients did not have the same quality metrics as the practice out on the main line, where everybody had commercial insurance and a personal coach. But we had good enough data to know directionally we're not doing as well as we would like to do for diabetes care for our patients. And we have a diabetes metric that we can quibble. We can spend the next 6 months quibbling over whether it's really the accurate data or not, or we can say it's certainly directionally correct. And if it goes up, that's bad, and if it goes down, that's good. So, because you can't, you could spend your whole life trying to get the best data. Again, that's why we do not advocate. And there's a place for randomized controlled trials, and if you all can pull one off, that'd be awesome. But it can't be the everyday, and you just can't, there's not enough resources to do that. One other thing I'll say as Shelley's moving the mic is the qualitative data is absolutely critical. And that's where I would encourage you to invest your limited time and resources, is to look at qualitative, both learning outcomes and health outcomes data. Talk to patients. Is their experience different? We all have patient satisfaction data. It's actually terrible. I mean, it's just not good quality data because of the way it's collected. But those stories, those are powerful.
So this is our last question.
So I'm just curious, and I very much appreciate your insight and your the way that you delivered your ideas. It was wonderful to hear. With the educational, in an educational environment, it's really not hard to make an argument for, yes, this is good work, and yes, we should be doing this. I'm wondering on the other end, in healthcare systems, if you can just speak on championing the return on investment and what this means from a financial model.
Yeah.
And the reason I bring that up is because it feels like that is still kind of separate. That's a completely different line of education that often folks don't get until they are in the real world, in the real jobs. And you mentioned it, in your own career, and it feels like that is something that we need to figure out a way to integrate with bundled payments, and just so that folks aren't coming into fields and suddenly getting slammed with this reality.
Yeah.
I'm curious about that.
So I think there's a couple of levels there. I think it is imperative for us to teach our our students, talking about student learners, something about the business of their profession. How are you going to get paid? How are you not going to get paid? That kind of thing. So we have to do that, and help them to understand that it's in flux. And if they start their career in Portland and then move to rural Maine, it's going to be a different payment environment. And then if they move to Philadelphia, it's going to be different again. If they move to Denver, it's going to be different again. So, and in 2 years, it's going to be different than now, and in 10 years, it's going to be a lot different. So, but we do need to give them some fundamentals. But at the higher level, I think the really critical thing, look, I did not stay in academic medicine crying that I wouldn't have to manage a practice, right? That was not the thing that almost made me not stay in academics. That was a draw to go into academics, and I think that's not unusual. So we don't necessarily know, and I didn't really understand. I mean, I kind of thought I was smart about it, but I didn't know much about it until all of a sudden my paycheck mattered, So we have to educate ourselves, and I think a lot of that we can do in partnership, because I think equally folks in practice don't necessarily know what value we could bring to them. So I think we start not by saying, I want to do this in your practice setting, will you help? We just start by finding someone to start to have a conversation, have coffee once a month and talk about your problems and my problems, and you're going to start to find out that some of them are the same problems, or that you have a solution for that problem, and maybe they have a solution for your problem. So that then, because everything's about relationships and culture in my world, then you can start a project.
Well, I think we have a lot to think about. Thank you so much, Chris, and let's all give it up for Chris.
Well, thank you all. I'm looking forward to tomorrow, and I'm really looking forward to the bright future of you all continuing to lead the way in this space. So thank you all for your work.
Have a wonderful night. Have joy. Be happy. Be hopeful. Thank you so much.